I am here again for the second session, for the lecture for the Congress. Thank you so much, Chair, and thank you so much, President, for the invitation. For me, it's a big pleasure, and it's an honor to all of you to share my activity in my auditor practice. The rest of the speaker, congrats for your excellent presentation. I am neuroanesthesiology, and for this reason, I use different devices in auditor practice, not only for pain management. I use magnetic stimulation, brain magnetic stimulation, electromagnetic stimulation. I learned many years ago with the master, with the professor Olof and Nemo, the intravenous radio frequency that I use in my hospital, this technique, and I agree with this because in my first stage I use like you in intravenous for principal for stress oxidative in cancer pain, for regional complex syndrome with good result. But I have only 5 cases for the treatment with intraarterial approach. I have more or less 51 for intravenous approach, but for intraarterial I use in my patient in only 5 times. For principal, when the patient suffer right now problem and when the patient suffer another disease that they interview the problem in the artery. And it's a good result. Thank you for your support in this time. This is the principal restaurant in Madrid for pain clinicians because you have the opportunity to put one injectable inside of the burrata. The name of the restaurant in Madrid is the Picaporte. Look, this is specific for us, not for gynecology or another specialty. It's only for us. And you prepare the tomato, the trufa, and it's possible to enjoy when you visit Madrid. I invite you. No all. This is my problem. Doctor, this is for you, especially for you. This is my problem in the last year, the size of the foramen. And for this reason, many years ago, I used the fusing image with the MRI and advanced ultrasound in real time in the same occasion, or to look what is the size. You know, sometimes with the patient superstenosis, it's true that the foraminal maybe have one size of 2 or 3 millimeters. Normal, when you include the fat and you include the connective tube, the foramen is more or less 5 and 6 millimeters. It's very different when you look in a brain and in another exploration. But with OLR fusion image, I calculate in the past the size of the foramen for to look very good and for to put inside in the patients that suffer complex allergy or many occasions that I need to generate one vision here of the foraminal approach. This is the machine. The problem of this technique, I love this technique, but the problem is that it's not dynamic into a machine. For example, you have a static MRI with a dynamic ultrasound, and you need the CT for to put in ultrasound. If you have the opportunity in the future of obtain the two dynamic process, obviously you have a big power for your patient, for the control, and for the security and the safety for our patient. But I want to show this work in my past. Obviously, we talked about this morning about the 7-star scope. This was my first experience. This is my first patient. It's a chicken. I prepared the different process. I prepared the different protocol with this patient. I love this patient. My second target. In this moment, when I start to the use of the microendoscopy, no, in the future, in this moment, I don't think about the pelvic pain or spine. I'm working in one important oncology hospital, and we receive many pleuritis pain, and receive many patients that suffer cancer in thoracic areas. I use every day a radio frequency for pleural space and for to put catheter inside of the between pleural space. And in the side that the patient suffered this retraction in between the visceral and parietal pleuras, which the patient suffered fibrosis and have pain, I use the radio frequency, interpleural approach. Always pulse radio frequency, not thermic radio frequency. Remember that I student from this doctor, and this is our professor and this, our influencer about the technique of the pulse radio frequency. And for this reason, I always use in the thoracic area a pulse radio frequency. And in this moment, it's possible for me to understand that it's possible to look the pleural space with the microendoscopy. This is a new approach that I use in this moment because I need to look what happened in the parenchyma and what happened inside of under and over the sliding of the pleura. Because when you use in the parenchyma and the long parenchyma thermical radio frequency, you produce more fibrosis in the lung parenchyma, and it's possible that you generate a little subpleural pneumonia, and you have a big problem for the patient that suffer cancer or that suffer fibrosis, lung fibrosis. This is more for intensive care. Sometimes I receive in my surgery room this kind of patient, and it's another approach for the use of the 7-star scope. Obviously, this is another approach that you use. Do you remember that the cardiologist using every day the degree of the deformation, the strain? The strain rate is used for cardiologists, and it uses in the pelvic pain because I need to know the degree of the deformation in tissue for the myofascial syndrome. This is more important because you know how many or how long is more tone than normal the principal muscle in pelvic floor or in musculoskeletal areas, in different musculoskeletal areas. Normally, I use like you different process to treat my patient. And for this reason, I create this my protocol, my fibrolaser protocol, for to present to you for first time in one congress. It's only for my patient and for my training in Madrid. It's possible for you to know perfect. I like to use the micro camera or the microendoscopy because normally in video, in presentation, in the live, is not good for you to look because you lose the normal intensity of the quality of image. But when you stay in the surgery room and you look the camera, it's fantastic for to exploration any part. You have the security, you have the safety for the patient, and for me it's new toys. It's just all today in the morning. This is the video that I put the video presentation. I don't want to repeat because I prefer show you another clinical case, like pelvic pain. This is, I repeat, this image, and I combine different devices to obtain the best result for my patient. 5D ultrasound, 3D ultrasound. 5D is the movement of the 3D, and 5D is for the crystal purpose new tool to increase the quality of screen in the ultrasound. This is my principal protocol. I prepare in my surgery room the checklist that I need to make for this case. And this is for the pelvic floor. I detect the side where I have the problem. In this case is the fibrosis in the perineal areas, and I put the fibrosis, and after that it's possible to look the hole after that I put, or after that I made the hydrodissection of this area. It's the same. When you make one hydrodissection, it's the same in pelvic floor, in the spine, in musculoskeletal, in fascia. I have for you one or two examples for this. Look, this is a new form for to prepare the patient or for to understand what happened. This is a transillumination in advanced ultrasound. Transillumination, remember when you have one myocardial infarction and the cardiologist will say that your muscle is not in good condition because don't receive or maybe have a posterior for myocardial infarction, the muscle have a little scar and you have a little problem with the contraction, but it's the same in the muscle area of the pelvic floor or in other areas. You need to know what happened around the hole, or maybe around the muscle, or maybe around the nerve, because maybe sometimes produce some traction for the nerve, and you have a problem for after the patient suffers one important neuropathic pain. This is more important. Look, the examination in real time of this case. In this case, it's possible for you to look at the transillumination and this 3D, 4D ultrasound in real time. It's possible to move. Remember, it's the high technology for increase the quality of life of our patient in this moment. With endoscopy, is a good machine, a good device for me in this moment. Look, when I use the radio frequency for pelvic management, I use the normal radio frequency. And through the radio frequency, it's possible for me to pass the laser. And in this point, is that I look the target that I need to look. And this is the big star in this moment for the microendoscopy. For the first time, you have the fusion of the ultrasound and microendoscopy, the camera is for you is special because it's possible for you to look the exact side that you need to put the tip of the needle. It's fantastic. For me, it's fantastic because I need this for spine, I need this for different nerves that is impossible to treat with another kind of treatment. This is another example with my friend, with my partners of the Quantum Evodos that is working with me to develop of this machine. Look, I put this video before and after. After it's possible to look the vascularization of the area that we need to treat previously, or to put fibrosis, or maybe to make one hydrodissection. The problem is that in real time, with one a little different, 5 minutes, 10 minutes, you have the control of your patient, and you don't have any doubt about the treatment that you made 5 minutes before. This is my team. This is my team, and look the quality of image. It's possible to look for us. Look the vessel, the nerve. Sometimes I use hydrodissection, but sometimes I don't need make hydrodissection with this microendoscopy because the anatomy permits the identify the principal structure that you need to treat in the posterior way. This is, I use the principal case for me. I have a lot of experience with the use of the microendoscopic for the pain management because I need for this complex patient, okay? Spine, musculoskeletal disorder, and pelvic pain are my principal target, and oncologic patient too. Look the resolution. In the resolution, it's possible for you, when you open one foramen, one part that you treat, it's possible to look the vascularization, and it's possible to look or to calculate, to measure the size that the foramen, or that any part that you need. This is the advantage that we come with this. This is 5D ultrasound for to look the hole in this moment after the treatment. Look, another example. Look, this fibrosis. This is fibrosis. It's fibrosis. It's more hard. It's very difficult for us, the control, without 7-star scope. But if you have the technology and you have the laser, it's possible to put the fibrosis and resolve the problem of the traction of the nerve. This is the gold standard in this moment for pudendal entrapment. This image I present for you, spine. You look this video previously. You look this is the 7-star cost for the spine, for the facet, or for the you want. Remember, this is one important approach for to look. Okay, is you need some time. Imagine that with the patient don't have any response, positive response for this kind of treatment or for identifying this part, we need to send the patient for the neurosurgery, obviously, or traumatologist. I don't know what specialist is working with you for this, for the surgery resolution. But in my hospital is neurosurgery is the boss of this case when we file the different procedures. Looks, another fibrosis. It's possible to look. And our slogan is you see, it's possible and more easy to treat than the problem of the patient. To see or not to see, that's the question. Another example. Fascia transversal, hydrodissection of the fascia. Sometimes the problem is not in transforaminal approach, it's not in the spine, it's in the muscle. The physical therapist says, my patient has a big problem in the myofascial syndrome. Okay, but I prepare one special block and one special hydrodissection of any fascia, and the patient is more easy to restore for the normal life. Cancer pain, obviously, we need to check where is the problem in the primary or secondary cancer. And I use, like say you before, that I use for cancer pain, I use laser and cryotherapy. Okay, cryotherapy, because it's for the control of the pain immediately, and it's good for the patient. This is the image that I shared with you 1 hour ago. Look, the control of the scar is easy. I pass with neodymium jack, maybe 2 or 3 pass. I don't need much energy, only sometimes 50 joules with neodymium jack is sufficient for the control of the scar and disappear. This is for pancreatic cancer pain, anterior approach. When we have a big problem for the posterior approach, is fantastic they use. I passed this slide before too. Regenerative medicine, I explained to you that I use for pain, I prefer always I prefer for pain bone marrow, because have more anti-inflammatory effect than the stromal vascular fraction from fat. Depends of the regulation of your country. Sometimes I visit different countries and I use different process and different technique that maybe in Spain and in Europe is not good, because we don't have we have a hard regulation for this. Sometimes I use in different countries different technique. But in Spain I use bone marrow. I put in the spine, I put in the facet, I put in the joint. I need the patient for principle for anti-inflammatory effect and viscosupplementation effect. Okay? Not for regenerative also. The patient suffer one important degenerative joint problems. Number 4, it's impossible to restore to number 2. It's totally crazy thing, another form of treatment for this patient. Look, this is my technique, and with the 7-star scope, you have the opportunity to put the stromal vascular fraction from fat or maybe bone marrow in the specific area that the patient needs for to restore, for to increase the bioactivity of the tissue that suffer injury or damage, or like a nerve. If you have one important nerve that suffer one important innervation, it's possible for you to put a stem cell around the nerve and to make the control with the neurophysiologist to prepare for a neurophysiological study before and after, and you compare what happened after that you use. I always combine, if the patient has super neuropathic pain and I have the control of the electrophysiological study, I use always pulse radio frequency and biological products, okay? For to restore the neural nerve. This is my technique for bone marrow, maybe in the ilium crest and in the tibia. No, in the sternum. In the sternum I don't use because it's more pain for my patient. We are anesthesiology, pain, physician, pain management, and it's totally crazy to push. This is my technique. It's easy. In only 3 seconds, 4 seconds, I obtain the bone marrow. Cryotherapy. Normal, I use this technique because imagine that if you need one specific target, this technique for cryo with X-rays is not good. I prefer always the ultrasound because it's possible to look the ball of eye in the perfect side that you have the nerve. Obviously, this is for peripheral condition. But if you have the cannula of cryo, and if you have the cannula of a 7-star scope, you know the perfect side for the patient. I use, this is my machine, it's from Cryo Spineless by Beatrice, and this is it's perfect because we have one anterior concept that we used many years ago with cryo. We use only one lesion, but in this moment you use 2 lesions, freezing and defreezing, because the more intensity in the second lesion is more effectivity for the patient, and for this reason you need to process, and this is good for our patient. The results are fantastic. The problem is, the only problem in this moment is that in Spain it's more expensive for the patient cryo than normal radiofrequency, okay? Look, example, by ultrasound, it's possible to look these phenomena. You know this phenomenon is aliasing. Aliasing is when you obtain different colors in the Doppler and the flow is crazy flow in this moment because the probe of ultrasound receives this information and have important aliasing. This is the gas from the cannula, and I use obviously my another baby. And for this reason, the lecture for today for the World Congress is the use of microendoscope and use the cryotherapy and use the fibro laser through the microendoscope. You have different approach for different disease, and obviously if you have the microendoscope, you use the cannula through the microendoscopy, or through the cannula, you put the microendoscopy, you put the cryo. Erected dysfunction, I shared with you 1 hour ago. Remember that the concept is to look how many milliliters, how many volume do you need to increase the sexuality, the quality of the sexuality on our patient. The patient suffer pain, but if you resolve the pain, the patient said, "Doctor, I have another problem." And you need to restore another problem in the patient. Remember, pain and restore the functional and sexual activities. Uddental posterior approach. I showed you this image previously. Obviously, you need to anatomic, you need to pass the cadaveric course, but it's important to practice or to understand the space, the size of the muscle, of the foramen, for after that, you found the best decision for our patient. Thank you so much for your attention.
Thank you very much for Dr. Delgado for your nice presentation. Maybe we have time for one or two questions. Is anyone in the audience who would like to comment or ask for a question? Well, then I think we can always approach you during the tea time because it's already late. So it's my suggestion, and I hope you agree. You will all be available, all the speakers, at the tea room, tea time. So now I think we have tea or coffee or whatever, and in 15 minutes I hope that you can be back. Is that okay?
Okay.